Yeah. Okay, fine. The door is closed and the rumor is outside. So, dear auditorium, let me welcome for the session about hormones in adolescence, which is very, very important part of PhD work because we see these patients daily. And let me not to waste the time, just invite and welcome our first speaker, Miriam Gushvili. Miriam is coming from Georgia, and I must say she is very active and very nice person and PhD representative of her country. And she is that one who succeeded to form the first group in the history of her country. So this is a big job what she done. And now, Miriam, the floor is yours.
Thank you. Thank you for welcoming Belgrade, Serbia. I'm very pleased to show it is not half done. My research, it is not fully done. It is in progress. We are planning to finish this research in 1 year minimum, but maximum we don't know because it depends not only us. There's no interest conflict. This research is winner of Shota Rustaveli National Science Foundation of Georgia. It is $25,000, like our government gives us to make more improvements this research and to make some lab tests and technical supports. Georgia is like little country. It's like between our neighbors are Turkey, Armenia, Azerbaijan, Russian, and I'm pleased to say that in the greens there is like 20% of my country is occupied by Russian, but other parts are very motivated that one day we will be again full country. So to tell you about why we have decided to start this study, to start the PCOS, the current population of Georgia nowadays still 4 million. It is not very much, not huge people, and we don't have the real number of PCOS cases, how much PCOS cases we have in adolescents, and not only in adolescents, we don't have this current numbers. Energy homeostasis in adolescents with polycystic ovary syndrome. It was a very interesting field for me that approximately 25% of adolescents with PCOS have metabolic syndrome. But there are other portion of PCOS patients when they don't have the metabolic syndrome, there is no high BMI, and also during this time I understand there's ethnicity plays a very high role during developing of PCOS. So it's like Georgian food. Why I mentioned this, because it is like ethnicity plays a role during the development of PCOS, and this is like our national khachapuri, khinkali. So this is like our mostly very high carbohydrate foods. Not every day maybe we are eating, but twice in a week, 3 times in a week. Maybe if somebody will make bakes in my home, I will not be regret to eat, for example. So, and the most of people, so fast food is this. My friend tells me, do you know in Georgia, not like such big fast foods cannot work. Why? Because we are eating our khachapuri, which is very high caloric intake. It contains very much. So the cause of PCOS, it can be heritable, non-heritable, intrauterine, depends on extrauterine factors. So now we have decided to, of course, the diagnosis, it's very hard for me when I'm working with adolescents, and also not only adolescents, but with adolescents it was very hard because there is some difficulties to make directly when they have the PCOS, because they have anovulatory, it's also normal, they have a little hyperandrogenic state, they have acne also during this time, and also for morphological. But in Georgia, by my practice, when they are 25, 26, they already are diagnosed by all of these criteria PCOS. When I checked their history from adolescents. They already noted that they have the problem during the puberty. Yes, Maria, we have this such puberty problem, but nobody knows, nobody gives us good recommendations. Diagnostic criteria change frequently due to the diversity, because it can be clinically and diagnostic markers change every time. Mostly it can give what is the problem that now when I have not only adolescents, they have already infertility, metabolic syndrome, type 2 diabetes. We have high rate type 2 diabetes mellitus in Georgia, cardiovascular disease, endometrial carcinoma, and estrogen-dependent cancers also we have. And when we check deeply, they have the PCOS together. So what is our goal? Studies in adolescents to identify currently known and probably risk factors, which will help to identify early identification and prevention. We are mostly motivated to make the prevention, which gives us less medical and social, of course, costs. The aim of this study was to determine the importance of energy balance in the pathogenesis of PCOS in adolescents. As we know, this is like we take the criteria for to diagnose it is hirsutism, acne, menstrual irregularity, and plus and minus obesity. Approximately 20% of patients are non-obese in our country also. Due to this, I will skip a little bit. Methods, what we take, what we want to check till nowadays, it is like adolescents from 12 till 19 years old with BMI when they have normal BMI. But they have any one of the criteria which can be the risk factor of PCOS. It can be abnormal menstruation pattern. It can be hyperandrogenic, hirsutism, or acne. And it can be one clinical laboratory signs of PCOS. It can be like testosterone high level, 70-Hosh progesterone high levels. And of course, we exclude any kind of disease which can give, for example, the adrenal gland problems. If there is some problems, any kind of problems of abnormal menstruation and acne also. We performed indirect calorimetry, total testosterone test, and identify risk factors throughout special designed questionnaires. I did not show these questions, but it's very detailed about what's the lifestyle. When we are talking about lifestyles, okay, it's what is your lifestyle? It's normal. Everybody answers is that it's normal. But when I'm giving there's 10 very detailed questions about sleep, about what they are eating, how healthy they are eating. Because sometimes I'm asking to a mother what she is eating. Oh, she's eating everything, like fish, yes, sushi. Sushi is not only like fish content, it's like also rice. They are not eating meat. They are not taking so much protein intake. It's not so much when we detail these questions. So in my hand, we have also such little papers we make about indirect calorimetry to explain very directly what it means. This is to make the presentation. We are detecting like how many calories during the resting metabolic period they are using and calculate. Of course, we are checking the androgen level by Ferriman-Galloway scoring, because for adolescents it's very important. They are coming, and when I am making scoring of hirsutism, because the chief complaints can be hirsutism, but it is not hirsutism, because we are Caucasian. We have our score must be more than 8. It cannot be like 4, 3, but she's adolescent, she is teenager. It is problem for her, but such patients we also exclude in our research. Of course, about acne. Acne, it's like common. Everybody who have puberty has little acne, and because like Instagram, like TikTok era, every young lady has the problem of acne. So in this table we are making more detail about acne. Results, what we got result, it is like we have 40 patients from 130 ladies. We get this 40 patients who have the real criteria for PCOS, and we made like lab tests also. In the lab tests, here it's already written only testosterone, but we are making insulin, HOMA index also, but now it's under research. And we are also checking about their association with all chief complaints. And about indirect calorimetry, what is very interesting, it was that 75% has increased, not decreased. They have increased in direct calorimetry. Only 2% has normal resting metabolic rate, and only 20 has already decreased this factor. So this is our result. Discussions. The preliminary results show that variability in the testosterone concentration in most patients, according to literature, it is currently believed that typical hormonal change are not always present. It is not known that during PCOS, testosterone concentration is slightly or moderately increased. We don't have very high increased testosterone level, for example. About energy state, has been studied in many ways, but the assessment of energy status has never been the subject of research. In our options, PCOS develops suchly negative energy balance is formed in the body, the background of qualitative proteins and fats intake, energetically insufficient food intake, exercises, and which is particularly confirmed in our also results. The PCOS deviations are considered diagnostic markers of deviations. Paradox, this is because nutritional deprivation is very important. Again, we are telling in order to develop solid scientific basis of improving clinical diagnostic and subsequent management of patient, it's necessary to consider that PCOS in adolescents, it can be sometimes suboptimal health status, because nowadays it's becomes very common and determines the importance of energy balance. When I'm telling what to eat to my patient, I want to give direct caloric. Maybe I'm telling you have to make the diet, but what kind of diet? She must know, I think. Thank you. Thank you very much. This is our little Phyllis in this picture.
Thank you very much for your work, and just keep on going. Based on the WHO projections, now we have reached 8 billion people in the world, 1.5 is obese, among them 300 million children, less, half of them are girls, so it's a common problem. We decided with Zsuzsanna that the first three presentations are about PCOS, so we just hear them, and then after the first three we are going to have questions and answers. Okay. So shall I call on the floor Michael Yaffe? If I read correctly, you are from University of Texas, right?
Correct.
Okay, and type 2 diabetes, PCOS, go on.
Well, thank you so much for the chairs of this session and for the committee of the Congress to ask me to present. I am a pediatric endocrinologist by training, and I am the division director and fellowship program director. And the idea behind doing this screening study is to put some focus on other problems which were associated with type 2 diabetes. We often focus so much on diabetes, and we tend to ignore or forget about other metabolic problems that also occur with this. Next, please. So nothing to disclose. Next. So the obesity-related type 2 diabetes in children and adolescents has reached an epidemic level globally. This is exactly what you have talked about. I basically practice in Houston, Texas. Texas is one of the most obese states in the United States. Houston was considered the most obese city in the United States in 2012. We keep holding big record, unfortunately. And this gets translated into a very high level of obesity, pre-diabetes and type 2 diabetes in children. The issue with type 2 diabetes is that it's not only diabetes, it's part of the metabolic syndrome, which often includes hypertension, dyslipidemia, non-alcoholic fatty liver disease, NAFLDA or NASH, and also PCOS in females. The other problem in diagnosing PCOS is the challenges related to the normal physiologic events that occur normally during puberty: acne, hirsutism, irregular periods. Next. The aim of this study is to evaluate any kind of documentation of PCOS in female teenagers who are diagnosed with type 2 diabetes based on a retrospective chart review. Basically, I did this as a retrospective study, but then we used the results and right now screening for PCOS is standard for our patients in the diabetes clinic. Now, many people ask about how would you diagnose type 2 diabetes, because if you have a huge population of obese kids, they can be also predisposed to get type 1 like any regular kid. And so how do you differentiate an obese child with type 1 diabetes versus type 2 diabetes? So basically we did that based on insulin level, lab results, C-peptide, lack of autoimmune markers of type 1 diabetes, and we assume that this is type 2 diabetes. Also, the presentation is usually milder, but again, during the COVID pandemic, we saw more severe presentation of type 2 diabetes related to the delay of seeking medical care. That actually has been another field of study that we have been working on. Next. So we looked at retrospective chart review over 3 years period. Pre-pubertal females, of course, were excluded. And this is also another remark. Sadly enough, we are seeing type 2 diabetes at a younger age. Every 5 years, we start seeing younger kids with type 2 diabetes compared to the 5 years before. The youngest was 3.5 years old that I personally diagnosed in 2015 and was considered the youngest kid ever reported with type 2 diabetes in the world. So we looked at the age, race, body, BMI, blood pressure, hemoglobin, A1C documentation, dyslipidemia. What has been done? We always get the metabolic panel. We look for liver enzymes. And the PCOS screening was more difficult because we had to depend on medical history, review of system, androgen level, and pelvic ultrasound when done. Not every patient had all of these findings. Next. So we had 26 female patients diagnosed over 3 years period. This study was done probably like 5 years ago. So right now, if I do it again, we are going to see much higher number. The average age of diagnosis was 16 and 3 months. 61% were Hispanic, 30% were African American or blacks. Average hemoglobin A1C at diagnosis was 9.8%. Other comorbidities were hypertension. We saw it at diagnosis, 34%, but 15% remained hypertensive after the diagnosis of diabetes and required therapy. Dyslipidemia and elevated liver enzyme were very common, especially elevated liver enzyme. I have another series of studies in which I found out that elevated liver enzyme or NASH was the most common presentation in one subgroup of population, the Hispanic population. Almost 69% of females had history of irregular periods, but only 5% had elevated testosterone level. And one patient was initially referred to gynecology because she had persistent menstrual irregularities. Next. So I think that one thing that we have learned as a group in my practice that we should focus on PCOS feature at the beginning of type 2 diabetes. The diagnosis of diabetes is often overwhelming for the patient, for the families, for everyone else. We focus on providing nutritional consult, diabetes education, but we really need to investigate other hormonal abnormalities. And we basically use this study to include screening for PCOS as a standard of questionnaire whenever we face with a patient with newly diagnosed type 2 diabetes. So we know that PCOS, if you talk to the adult colleagues, they always tell you that PCOS starts in puberty, and it's usually very difficult because normal pubertal features carry some features of PCOS. One of my mentors many years ago had a theoretical suggestion that PCOS is a theoretical prolongation of the pubertal status. Again, this is very important, especially related to diabetes, and we really need to focus on providing PCOS follow-up and care, and referring patients with PCOS to gynecology for further evaluation and treatment if necessary. So I think I'm done. Thank you so much for giving me this opportunity. It's a great honor to be in Belgrade.
Thank you very much. Thank you very much, Michael, for a nice presentation. And please keep questions for the author to the finish of the next presentation. And now let me invite authors from sunny Italia, from Cagliari, from University of Cagliari from Italy. And they have very promising title of their work, Ovarian Ultrasound together with circulating androgen in PCOS. So we are eager to know about your topic. The floor is yours. Stefano Di Michele and Elena Pittui.
Thank you.
Yeah.
I'm Dr. Elena Pittui, and he's my colleague, Dr. Stefano Di Michele. As you already know now, we are from Cagliari, and we are resident. So this is our study. We have nothing to disclosure. As you know, PCOS affects an important part of the female population. This has great complications, which are mostly cardiovascular disease, endometrial carcinoma, and metabolic disease. We have studied the correlation between the ultrasound ovarian stromal examination and the steroid hormone profile. Diagnosing PCOS isn't that simple because we have problems in interpreting data, in valuing the clinical factors, and in valuing the ultrasound factors. So we studied a correlation between the ultrasound and the steroid hormone profile, dosing through the gold standard method, liquid chromatography and mass spectrometry, the principal androgens. We enrolled 44 patients, and the patient recruitment had as inclusion criteria the PCOS and the PCOM in line with the Rotterdam criteria. The patients were enrolled during the early follicular phase. Exclusion criteria was the presence of other endocrinological disorders, other hormonal therapies in the previous 6 months, and previous ovarian surgery or the presence of a single ovary. So we enrolled our patient with an early follicular phase blood draw. We centrifuged the blood sample, and we sent the plasma to Bologna, where they dosed testosterone, androstenedione, and 17-hydroxyprogesterone with the liquid chromatography and mass spectrometry. On the same day, we did also an ultrasound, and we, with a caliper, we divided the stromal area by the ovarian area, and a value greater than 0.34 was considered as a stromal hypertrophy. We did a video, but it doesn't work. So we use a caliper to separate the ovary from the stromal area, not including the follicles.
So, deepening down the hormonal study of patients with polycystic ovarian syndrome, we have seen that basing on the androgens level, we can subdivide phenotypes depending on the hormones patterns that they have. These are our results, and we have seen a significant correlation between androstenedione and DHEA and the number of ovarian follicles and ovarian stroma. Moreover, we have an important correlation between androstenedione and the stromal area, plus the 17-hydroxyprogesterone is correlated with stromal area ovarian area ratio. what is very interesting is that we have found no specific correlation between testosterone and the ultrasound parameters. This contrasts with previous literature where testosterone was always correlated with patterns on the ultrasound examination. So if we try to compare these two methods, we see that liquid chromatography associated with mass spectrometry has higher sensitivity on androgen hormone detections. So we believe that PCOS population is more hyperandrogenic compared to a first esteem, where hormones were collected with the standard immunoassays. So we want to say that we should give a greater importance of the androstenedione when we consider the biochemical pattern of the polycystic ovarian syndrome population. Therefore, we can assess that immunoenzymatic methods cannot be reliable, specifically when we try to diagnose very borderline clinical situation. Limits of our study is the limited number of patients. It is difficult to find a center where they can perform the liquid chromatography associated with mass spectrometry. And also examinators, they must have specific skills on the ultrasound, as we have seen, because it's not so easy at the beginning to try to exclude the follicles to the ovarian area. There is a lack of distinction in our data between the transabdominal scan and transvaginal scan on the ultrasound examination. What we would like to do in the future is to increase the number of patients and to include within the ultrasound examination the 3D scan. Concluding, we can assess that the stromal area and ovarian area ratio is confirmed as a marker of high importance on the biochemical and hyperandrogenism correlation. And for this reason, we believe that its use in clinical practice in the ultrasound diagnosis of polycystic ovarian syndrome is potentially useful and reliable. Thank you so much.
Thank you for really very interesting presentation. And now we finished with the topic of PCOS. So please, if there is floor for some questions or remarks on these three presentations. Yeah, I see the first raised hand, and it is Jana Bomboliene.
Maybe my comment is together to all the presenters, because you measure total testosterone. Total testosterone is unrelated. In most of cases, and especially we see the diagnostic criteria, they speak about free testosterone. Or we must measure sex hormone binding globulin and then calculate free androgen index. And it will be a little bit different because sometimes we see normal testosterone level, but if sex hormone binding globulin is very low, and in most of cases it will be very low. So free androgen index will be high, and it is the sign of hyperandrogenemia also. So it is to all of studies the same remark. I think that it may be useful.
Anna Maria? Yeah?
Choose to verify also the free testosterone, also the SHBG, and the androstenedione, because but in our work the testosterone and androstenedione without the calculation of the SHBG levels may interpret better the level hormonal, but for our point of view, functional or holistic, your comment is very true.
Yeah, thank you. Anyway, it is really nice, or we appreciate a lot that this study was carried out because it is necessary to think about that final diagnosis of PCOS in adolescents is very doubtful as the developmental differences there are. So to find some tool which could be helpful in real diagnosis or for the future of the patient is fine. And this is really inspiration. I see Miriam.
I want to make some, because our research is not fully done. Now, in 3 months, we are giving this lab test to our patients to make, because this lab test we are done by family doctors or by themselves. It is not done by us. It was very important. And about testosterone, there is a one note from laboratory. There must be specific machine to make the measurement. And in Georgia, we have the problem with this machine. It was broken. Yes, to say truly. And due to this, many family doctors advised testosterone, total testosterone except free. But nowadays, we pay for this to make this machine, and from us, it will be ordered like free testosterone already, and also sex hormone binding globulins. Now, in our research, we include it, but they come with already, sometimes with lab tests already done. It's important because I'm working in insurance hospital, and family doctors are giving without us.
That's okay.
I think that improve your work with the measure of insulin resistance will be very useful to interpret better your results.
Okay. Just before we go on, one remark to Michaela. I think the 3D ultrasound scan is going to make it much more accurate because you are just scanning a coronal plane and it's not the whole volume. So that I think it's a good idea to move on for that direction.
We have a new ultrasound where we can perform that technique.
Yeah.
So we will surely include.
It's gonna be more accurate, but it's still good. And one question to Michael. 26 patients were enrolled. Do you have demographical data about their gestational birth weight, or whether they were birthed from mothers with very large BMI? No, unfortunately. Could be good to know because intrauterine surrounding can have an effect on that. Okay, we just go on.
Okay. Yes, last very quick question, please. Yeah.
So recently we see there's a trend towards prenatal androgen exposure for the development of PCOS, phenotype itself. I was just wondering, do you think prenatal androgen exposure could also give an increased risk of metabolic syndrome for these young girls?
Well, there are so many theories about the development of PCOS, and this is one of them. But I think it's very hard to tell as a cause-effect relationship. And the typical question is PCOS starts before obesity and it predisposes to obesity, or does obesity cause PCOS? Good point.
Nice point. Thank you very much. And now let me to invite Li Tzu from Ziyang. Do I pronounce it right? From China, to turn your attention to delayed puberty. Floor is yours, Li Tzu.
Thank you. Today is my honor to be here to share the presentation. Today, my topic is about female delayed puberty due to 17-alpha hydroxylase deficiency. This is a case report. First, I would like to introduce this case. This is a female who came to our department 9 years ago. At that time, she was 16 years old. Her chief complaint is absence of secondary sexual characteristics. About 1 year ago, she came to the other department when she was 15, and she had many examinations, which you can see from this picture. She had a high FSH and high ACTH. Also, she had the hypokalemia. The chromosome is normal, but the bone age is obviously delayed, which is about 10 years old. However, the progesterone it didn't be tested. So she had a primary diagnosis was CAH17 or HD. So she was given hydrocortisone for 1 year. However, she still have no breast development, so she came to our department for seek the estrogen therapy. The physical examination is there's no breast development, and the vulva and the vagina was infantile. The other examination shows that the pelvic ultrasound MRI, the uterus and the ovary is not shown, and the pituitary MRI is normal. So she had the primary diagnosis, primary amenorrhea, hypogonadotropic hypogonadism. CAH was suspected. So we give her a gene test. It shows CYP17A1 gene was mutated. Then the final diagnosis, CAH17 or HD, hypogonadotropic and hypogonadism. So she was given hydrocortisone and sex hormone replacement therapy, and also the symptomatic treatment. This is the gene result. As we all know, for girls, the first physical marker of puberty is celiac. The menarche is the late marker of puberty. For this girl, because she has the absence of menarche in more than 13 years old without the sign of pubertal development, so she has the primary amenorrhea. We know that there are many reasons can cause the amenorrhea. For this girl, she has a high FSH because the gene mutation, she have the defects in steroid genesis or receptors. The test about progesterone should be done for the diagnosis. We know that CAH is a group of autosomal recessive disease. 17-OHD is rare with a global incidence rate about 1 in 50,000, accounting for 1% of all CAH disease. In Brazil and China, 17-OHD is the second most common type. 17-OHD is caused by CYP17A1 gene mutation. This kind of mutation can cause partial or total loss of P415C17 enzyme activity and disorder of cortisol and sex hormone synthesis. For this kind of patient, because the lack of 17 hydroxy, the right side hormone will decrease, but the left side of the picture was increased. Because the lack of cortisol and sex hormone, it will secrete a large amount of ACTH, FSH, and LH. It will result in adrenal cortisol hyperplasia and abnormal sexual development. The production of 11-DOC will result in hypertension, hyperkalemia, and inhibition of plasia-renin activity. Because the high level of cortisosterone, it didn't have glucocorticoid deficiency or adrenal crisis. According to the clinical manifestations, steroid composition analysis and ACTH excitation test can be diagnosed. If necessary, the gene test will make a definite diagnosis. So the hormone replacement is very important. They need a small dose of glucocorticoid. For children and adolescents, hydrocortisone is often be selected. Sex hormone replacement is also very important. For this girl, she has the estrogen and progesterone replacement to induce artificial cycles. The last part is about the conclusion. For patients with undeveloped female secondary sexual syndrome, regardless of the performance of genital ambiguity, we should pay attention to blood pressure, need to consider the possibility of adrenal disease. Do blood tests include electrolytes and sexual hormones, especially progesterone, and ACTH, 17-alpha OHP, and the steroid components. Karyotype analysis is also be needed. If it's possible, it can have the gene test. If the 17-OHD is diagnosed, hormone replacement therapy should be given in time. For the physicians, we need to recognize the disease, early diagnosis, timely treatment, and improve the quality of life of this patient. Here's a reference. This is the girl who, in this case, right now she is 25 years old. So she is very beautiful and confident. That's our team. Thank you very much.
Okay, thank you very much. I think we just have the next speaker coming, and then we can have questions and answers for the last two presentations. So may I call Jerily Azari, right?
Yes, that's me.
Okay, who is going to talk about Indonesian JAMU-induced hyperestrogenism and dysfunctional uterine bleeding.
Thank
Floor
you.
yours.
Thank you very much. I did my PhD in PCOS, but I will be presenting on estrogen today.
That is nothing.
So I'm going to talk to you about a patient we recently managed, Indonesian JAMU-induced hyperandrogenism with endometrial polyp as a cause of DUB in adolescents. It's a case report. I'm from Malaysia. I flew about 18 hours to get here. I'm not from Indonesia, but we are tightly knit to each other. Okay, so we choose to come to Belgrade because I want to experience the change in time, weather, language, people, and the menu. It's just great. Okay. So background history about our patient. She's a 17-year-old Indonesian girl, presented to a GP for prolonged heavy menses for about 47 days. She required some sort of admission and blood transfusion because her HP at that time was only 3 grams. On scan, they noted that she had thickened endometrial with an estradiol level of 3,758. She was subsequently referred to us. On our assessment, there was some weight gain. There was no significant gynecological history or family history. She has been taking this traditional JAMU medication for a smoother skin for 6 months. That's 2 tablets, 2 days for 6 months, and there is no missed pill. Mother had took the same exact medication in her teenage years with no issues. We stopped the medication immediately. On examination, yes, she is absolutely beautiful, porcelain white skin, those that you see in Victoria Secret runway. Beautiful girl. Her BMI is 23. General, abdominal, and vulvar examination were unremarkable. Tanner staging for breast and pubic were also up to her age. This was a transabdominal ultrasound scan. We saw an endometrial thickness of 4.7 centimeters, almost 5 centimeters. We proceed on to the MRI, and here you can see there is an endometrial thickening, rising the concern of endometrial hyperplasia or even malignancy. For that purposes, we plan for laparoscopy and cystectomy, KIV, oophorectomy, and hysteroscopy, and polypectomy. What we found intraoperatively is that the peritoneal cavity, uterus, fallopian tubes, ovaries were all normal. Pouch of Douglas was also normal. There were 1 small paratubal cyst, which looks benign to us. So this is the uterus, left ovaries, right ovaries, the paratubal benign-looking cyst. When we proceed on to the hysteroscopy, we found fluffy endometrial with multiple polypoidal lesions. Osteomes are both normal, and we send those tissues for histopathological examination. There's no malignancy. The polyps are just benign secretory changes, and the paratubal cyst is also benign. So now we're scratching our head as to what's actually going on. 2 weeks later, she came back after being on cyclical Provera, which is progestogens. ET has came down to 13.8 mm, 1.3 centimeter, and she had subsequently regained her normal menses. So point number one, endometrial polyp itself is extremely rare in endometriosis. As we speak now, there's only 3 case reports. All have gone through hysteroscopy and polypectomy. The reason we need to do a polypectomy or hysteroscopy to rule out malignancy and to relieve symptoms. The question really is, do we really need to scan all our adolescents with heavy menstrual bleed? Second point is, what is considered to be normal estradiol level? Because it's quite difficult to standardize given the fact that the range of estrogen levels from 3 to 3,000 could range from a girl from prepubertal to postmenopausal women. In this patient, her E2 or estradiol was close to 4,000. At that point of time, we were also thinking that this could be a granulosa cell tumor as one of our diagnoses, but this tumor is extremely rare, plus she did not present with precocious puberty at that time. So we have some points for and some points against granulosa cell tumors. The points against is the fact that we didn't find any solid cystic multiloculated cysts. The points for is maybe because of an estradiol, which is sky high, and some case report, 5 case report, has got about the same kind of range of estradiol level. Then we thought about other possible estrogen secreting tumors. And when we couldn't think of anything else, we thought, it may be due to the jamu that she's been taking. Let me introduce to you the great jamu. Traditional medicine from Indonesia, and it's very popular among Malaysian people as well. It is predominantly herbal medication made from natural materials, but it has been proven in a lot of studies to be related to estrogen activities. Could jamu increase E2? Some mouse model has shown that it can increase the level of estrogen and progestogens, and another studies have shown that it increases vaginal epithelium itself. You can buy jamu online, on eBay actually, and when they advertise jamu, they will tell you that it can actually provide a well-balanced hormone, reduce vaginal itchiness, regulate menses, increase fertility, strengthen your uterus, reduce miscarriages, open up your blocked tubes, cure reproductive cancer, possibly put all of us in this room out of our jobs. This is a recent website I saw of how they actually advertise jamu. That's probably us at the corner that are holding on to our heads. So, I'd like to say thank you for listening to my slides. I've been told I allowed 7 minutes. I would like to also invite you to change your time, your weather, your language, the people, and the menu, and all the invitation that you have to go to all the European countries for your Congress. Nope, come to Malaysia. Thank you very much.
Thank you very much, Jerry Lee, for your case and also for invitation. And dear auditorium, please now questions to two last speakers. Yeah, Michael?
So I have a question regarding the CAH case.
Could we please a little bit more on voice or perhaps? Thank you.
I have a question regarding the CAH case. This is a very rare case and very interesting. The question is, did you do cortrosine stimulation test to look at the cortisol level after the stim test? And the other question, what about blood pressure? Did you see any change of the blood pressure before and after treatment?
It's a pity when she came to our department, we didn't have the blood pressure measure as usual. So at first time, she didn't measure the blood pressure. So, but the quite high ACTH and FSH, the endocrinology is quite familiar with this disease, but for our gynecology, we're not familiar with this disease. So they diagnose it without a gene test. And so we don't know if it's true or not. So we do the gene test to confirm is it right or not. But we are wrong, the endocrinology is right. So we need to pay more attention to the other disease, for example, the endocrinology disease. So we need to know more knowledge. We need to know more. So that's our experience.
Okay, then.
Yeah. Thank you. So anyway, your genetics has done really nice job in it. Any other questions? So perhaps I would like to ask Jerry Lee, what was the reason for laparoscopy in your patient?
When we did a scan, initially we saw a 5 centimeter cyst. I didn't put it up because I didn't want to have you asking me that question. Because when we went in, thank you. So yes, the MRI showed a 5 centimeter cyst. And when we went in, we couldn't find the cyst. I don't have an... Oh, thank you for understanding.
If we expect stimulation because of that phytoestrogen matter, so then even the ovarian cyst could be expected. So that's what was question. Only one remark: if we talk about the polyp, so then this is not a sort of dysfunctional bleeding, but the bleeding because of polyp. But anyway, it is remarkable that these phytoestrogens can cause such a big problem. It was published also a case of one girl who was from lavender farm. Her parents had a lavender farm. They were eating lavender. They were all cosmetics with lavender, and there was precocious puberty with cysts and heavy bleedings. So yeah, so it is. One must be very careful by using these traditional products. Then, so thank you.
Thank you very much. If no other questions, we close the session and wish everybody safe journey home. Okay.
Thank you, everybody.